Well, we're very blessed that we have 2 approved BTK inhibitors for the treatment of Waldenström's. There are also other BTK inhibitors that are also advancing in Waldenström's. We're also now talking about non-covalent BTK inhibitors like Ibrutinib, and soon we'll be talking about, degraders like BGB-16673, as well as the Nurix drugs. This is a very exciting time for Waldenström's. But how do we choose between the 2 approved, drugs, BTK inhibitors for Waldenström's? Well, we look at the genomics. What we've come to learn is that patients who are wild type, who don't have the MYD88 mutation, benefit with Zanubrutinib. Also, it looks like patients who have the CXCR4 mutation do much better on Zanubrutinib than they do on Ibrutinib. And this is based on the findings of the ASPEN study, which was just updated at the 12th International Workshop on Waldenström's. TP53 mutated patients also appear to do better with Zanubrutinib. So genomics play a very important role. We also do look at side effect profile. If you have a patient who presents with pancytopenias, maybe they're better off with Ibrutinib because we see that it's gentler on cytopenias. On the other hand, atrial fibrillation, big difference between Ibrutinib and Zanubrutinib. When you look at the data, patients do much better with Zanubrutinib in terms of seeing a side effect of atrial fibrillation. So I think, we're in an era right now where we have choices, which is all good. Choices are good, but being able to sort of to understand the underlying issues around a patient, as well as predisposition for some of the side effects that we just talked about, I think it's important in terms of reading out what the best option is for a particular patient.